So this will be relatively short because it turns out we don't really know very much about HFpEF at all. But I'm going to share with you what we do know, and hopefully some takeaway points will be very helpful. Okay, let's see. All right, here we go. So what the heck is HFpEF? This term is one, depending upon when and where you trained, that you may or may not be familiar with. People use all kinds of different terms. Diastolic dysfunction, non-systolic heart failure. I like HFpEF, heart failure with preserved ejection fraction, because it doesn't rely upon an echo diagnosis. I don't actually need to prove that there is diastolic dysfunction on an echo. And it emphasizes that this is clinical. Heart failures are a clinical syndrome, and it's someone who has that clinical syndrome with a preserved ejection fraction. Okay, so in order to have this, to be honest, there are still reaching consensus on the definition, and the research definition is the one that I'm using because they're doing a lot of clinical trials. So to get enrolled in a clinical trial of HFpEF, this is the criteria that you have to meet. You have to have some symptoms of heart failure, so things Patty mentioned. Edema, shortness of breath, dyspnea on exertion is really a very big one, which is why I put that as a second bullet point. Any person with exercise intolerance or new dyspnea on exertion, this is something pretty high on my list to consider. Their ejection fraction, again, for the research definition, should be over 45%. You will hear cardiologists quibble. Is 45 to 50, is that mildly reduced? I mean, okay, whatever. But the idea is it's not terrible, but it's not fully normal either. So 45% is the cutoff used in the clinical trial. And then I highlight this, as we did in the last section, to remind us that other things can cause the heart failure syndrome, in particular valvular disease, which is why I kind of highlighted that in this person's echo. Usually severe, you're not going to get symptoms of valvular disease until it's severe. But for example, you could have somebody, I could make up a scenario where I have a patient, in fact, like this. They've got moderate aortic insufficiency, and they have diastolic dysfunction, a stiff ventricle, and their heart rate is very low. So the combination of three moderate things is giving this man pretty severe symptoms, but no single one is severe. That said, usually, for valvular disease to cause heart failure, it's got to be in the severe range. So aortic stenosis, mitral stenosis, mitral regurgitation, aortic regurgitation, any left-sided lesion can cause this. But then also, as one of you pointed out, thinking about lungs, of course, COPD can cause exercise intolerance or dyspnea on exertion, but we can also have the long-term consequences of COPD with RV failure or pulmonary hypertension. Those things are not HFpEF. Those are separate defined pathophysiology, and they're treated differently as well. So very important to kind of rule out all these other things before we give somebody this diagnosis. So this is a slide just showing what I think everybody is aware of, which is it's looking at the proportion of hospitalized heart failure patients. This is in the inpatient setting. And in blue are people with preserved ejection fraction. In red are people with low ejection fraction. And then the black line is people in that intermediate range, 40 to 50%. So what you can see is that this is really on the rise. That's probably because we're recognizing it more. But the estimate is that half of all heart failure patients actually have HFpEF. So this is a diagnosis that if you're not making it, we're probably missing something because it's very prevalent and it's really out there. But it's a challenging diagnosis to make for certain. All right, basic science, but this is just to say we have absolutely no idea. So there's some ideas about how some of the factors that we have observed that are risk factors for HFpEF, how they could potentially cause basically decreased energetics in the cardiac muscle and decreased function in terms of relaxation, but we really don't know. This is all hypothesis, nobody actually knows. But I wanted to point out in the upper left, you see that box that has some of the risk factors: overweight and obesity, hypertension, diabetes, COPD, and iron deficiency, which we touched on a little bit. So that's, I don't know, every patient in your clinic probably. In my clinic, that's almost every patient. So there's certainly the metabolic syndrome in and of itself can certainly lead to this condition. So it's good to have a high index of suspicion. But nobody knows what causes it. Hopefully we'll know more soon. There are some disagreements about what is the classic patient who gets this, but this is what I tend to see, and this is when I have red flags being raised. So it seems like more women than men. sort of middle-aged, around age 60, with obesity, hypertension, diabetes, and then there's a lot of them with AFib. So when you said that, Patty, it also triggered in my mind. About a third of patients with HFpEF also have AFib. So these things should, again, be raising some flags. Is there HFpEF going on aside from just all of these other risk factors? If you look at anything from Mayo Clinic, they're going to tell you that it's skinny little old white ladies because that's who lives in Rochester, Minnesota. But in other places around the world, that is not necessarily the case. In Baltimore, there's a higher preponderance of African Americans with HFpEF. I think nobody really knows that part of the demographic yet. So when I see a middle-aged woman with metabolic syndrome who can't catch her breath, this is on my list for what's going on, in addition to lots of other things, but it's certainly on my list. And I think what's challenging here is that we can often think, are they just deconditioned? Is this person just has poor exercise tolerance because they haven't exercised? Well, it turns out that the treatment might be the same, whether it's HFpEF or just deconditioning, but certainly something to keep in mind. Okay. So here's how I approach these patients. So someone's coming in with dyspnea on exertion or exercise intolerance. So for me, the workup that I like to do, and I'd be curious to see if anybody adds anything to this. This is also for me as a cardiologist. So much of the work has usually been done already by you wonderful folks who are thinking about a lot of other causes. But here's the things that I think of. So an echocardiogram is always going to be first on my list. That's not always a luxury that you have, but I want to know systolic dysfunction because that treatment's going to be very different, valvular disease, etc. PFTs, I love how everyone was bringing up smoking history and COPD because of course that's going to be very common. And sorry that the spacing got messed up a little bit, but a stress test or a cath. So exertional dyspnea can be a coronary artery disease equivalent. And so if I'm seeing someone with risk factors for coronary disease, which is basically these patients, and they're having exertional dyspnea, I'm absolutely going to do a stress test and rule out coronary disease as the cause before I jump to this diagnosis of HFpEF. So I think that's a very important diagnosis to make or rule out. And then as you were all pointing out, anemia can certainly contribute. I will say, having recently moved to Reno with higher elevation, I am just amazed at everybody's hemoglobins because they're much higher here than what I was accustomed to at sea level. But I think that this is a really important contributor. TSH, of course, can also be an important contributor. Now, every once in a while, depending on what I saw in the echo, if I see a big RV on the echo and this is not a person with COPD, I might be thinking about some other rare things like chronic thromboembolic pulmonary hypertension, and that's going down a different route. But a VQ scan to look for chronic disease, chronic pulmonary emboli is interesting. A 6-minute walk test is classically a test they do in pulmonary hypertension to see how able they are to walk. I just do it in my clinic. I have the MA walk them up and down the hallway a few times and just see what they do, right? Because there's nothing like watching it with your own eyes. I had a patient last week that I was convinced that she has HFpEF. Well, then she desaturated to, I don't know, 72% within the first minute of walking. So she needs oxygen. That's a different problem. So I think that's a very powerful one, even if you're not doing the, by the guidelines, measuring how many feet they're walking. And again, I think Dr. Bayoun brought up the heart rate. So if someone is having an arrhythmia that's out of control, 2 things that are possible. You can have symptoms from the tachycardia in and of itself, but you can also get tachycardia-induced cardiomyopathy where the EF drops because your heart rate's going 140. So a Holter monitor can be very useful to get a sense of that. And then I put BNP, brain natriuretic peptide, with asterisks because just like Patty's case, like I couldn't have scripted it better, what it perfectly pointed out is a couple of things. BNP levels tend to be lower in HFpEF than in systolic failure. So your level of 300s was very in step with the diagnosis of HFpEF. However, in the obese, BNP levels, they call it an obesity paradox. They can be normal in someone with obesity, even when they are completely volume overloaded. The idea of BNP is that when the atria is stretched, it releases this to try and help the body diurese naturally. But we don't fully understand if there's something in adipose tissue that soaks up the BNP. We don't really know. But it is quite common to see a normal BNP in an obese patient, even in overt clinical heart failure. So it's one of those tests useful if elevated, not necessarily useful if not elevated. But I think especially in your outpatient diagnosis, it's a very powerful tool because you can get that back much sooner than an echo. That can be helpful. And then the last point, which of course we all know, and as illustrated in Patty's case, you might have more than one thing going on here to contribute. And that's the challenge of medicine. Thoughts, comments, questions on this kind of my approach to this diagnostic workup by anyone? How easy is it to get things like a stress test, PFTs, and echoes where you all are practicing? We heard a bit about echo, that might take some time. What about stress testing capability? Do you all have that close on hand? No. You gotta send them to me, okay. I will also—
Dr. Warko has a question.
Oh, sure.
As far as the Holter goes, how long are you thinking is appropriate for that? You know, because that's one of the things. Like, do we do it for a day? Do we do it for 3? What's your preference on that?
Yeah, great question. So it depends on what I'm looking for. If I'm trying to find occult arrhythmia, I do as long as possible because the more data I have, the better. For someone like the patient we discussed with known AFib that I just want to sense, maybe he doesn't feel when his heart rate goes to 150. In that case, 24 or 48 hours, less invasive for the patient, but I still get the data because I just want to know what's their average heart rate doing. So if it's a first pass at diagnosing things, then I also ask them how frequent are their symptoms. If someone's coming to you with palpitations that happen once a week, well, then I need to do a 3-week test, which we're able to do in our office, so send them down to us. But as an outpatient, if I just want to sense, I try to do as little time as possible for the patient if I'm just trying to get an average heart rate. So 24 should be okay. Great question. I want to say one thing about stress testing because we have good data to help everyone not freak out. I think that we all get very concerned we're going to miss significant coronary disease, and that becomes, a driving factor. So if someone is having stable symptoms, their symptoms are with exertion, they're not happening at rest, the great news is that there is no emergency to the stress test. So we just had this big trial called the ischemia trial, and they took patients with true, legit angina, but it was stable. So they would have exertional chest pain, it goes away with rest. They got cardiac CTs, so we knew their anatomy, and they also had stress tests that they were positive stress tests. And then they randomized those patients to either getting PCI with a cath, so going and getting a stent, or just medical management. And there were no difference in outcomes between those two arms. Even in heart attacks, need to go back to the cath lab for a stent. So that really gave us even more confidence to say that stable angina is not an emergent diagnosis. So I know it takes a while for you to get that test, but don't let that worry you too much. If they're having crescendo symptoms, now I get symptoms, I take 2 steps and I have symptoms, that person needs to go to the hospital. But if it's just stable exertional dyspnea, you really do have time to make these diagnoses. So hopefully that can make everyone feel better. And I tell the patients that, but I very specifically tell them, if this starts to happen at rest or more frequently, then you just go to the hospital. That's the only choice. But for this outpatient workup, you can take the time and that's okay. Other thoughts, comments, or questions here? Okay. So let's go to treatment. This is easy, we don't know. So they've done trials, they've looked at ARBs, they've looked at ACE inhibitors, they've looked at nitrates, they've looked at sildenafil, Viagra, phosphodiesterase inhibitors, and we really haven't been able to show mortality benefit for any of the agents that we use to treat systolic heart failure, except maybe spironolactone. So this was kind of an interesting thing. There was this study called the TopCat study, and it was overall a negative trial, but if you take out Russia and the Republic of Georgia from the analysis, it is a wildly positive study with mortality benefit. Normally we discourage doing things like that, but as we discussed, this diagnosis of HFpEF is tricky to make. So what if they were misdiagnosing people in those 2 countries, which you can imagine can happen? So most HFpEF experts will put patients on spironolactone as long as kidney function and potassium can tolerate, because this is the best thing that we have so far. And then there are ongoing clinical trials that show a lot of promise, because right now it kind of doesn't matter, right? We're going to show you the recommendations, and it's like control their blood pressure, diurese them if you can, and good luck with that. But soon we will probably have an indication for Entresto, if you've heard of that new medication. It's the angiotensin-renin neprilysin inhibitor. And it has great data in systolic heart failure, and there's an ongoing trial, a repeat ongoing trial. It's probably going to show us some benefit. So making the diagnosis is going to become more important when we have specific agents to treat. So for right now, treating their hypertension is very important. And I really love what you did, Patty, of really getting onto these agents that even though they don't have specific benefit in HFpEF, all of us try to do that. We try to get onto ARBs or ACE inhibitors and beta blockers. Treat the AFib, diuresis for symptoms, and then I put in all caps exercise. There's actually a lot of data that exercise improves this condition. Well, that's really easy to get our patients to do. So, and unfortunately, as far as I know right now, insurance is not covering cardiac rehab for a diagnosis of HFpEF. But if you can get them into a cardiac rehab under any other diagnosis, you could say that their exertional dyspnea is an anginal equivalent, or try something like that. They really benefit from exercise. So here's what the guidelines look like, updated in 2017, but there hasn't been much new since then. So for those who are familiar, the first is the category or their level, sorry, the class of recommendation. So 1 is you must, 2s are you can, and 3 is you don't. And then the next one is level of evidence. That just tells you how good we have. And C means expert consensus. That means we have no data, but people just think it's a good idea. So most of these recommendations are at that level because we just don't have good data yet. But as you can see, blood pressure control is our strongest evidence. Diuretics for relief of symptoms is just the expert consensus. And then they're really trying to get them to that goal of less than 130. This is hard to do, and I'll be honest, even with all the data, I accept 140 in some patients, but for these ones, if you can really get them down, they can benefit. And then you basically manage comorbidities. So if they have coronary disease, you want to treat it. If they have AFib, you want to treat it. And then here you see, let's see if my pointer works. Oh yeah, there it is. So these are the agents that we recommend: beta blockers, ACE inhibitors, ARBs, etc. Oops, sorry, she's trying to give me a control. Oh, backwards, that's okay. Dun, 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 dun. We gave it away. There we go. You all can see where they're trying to give me a laser pointer here. Okay. There they are. Okay. So here is our what we recommend using. But as you can see, that's just expert consensus. But that's still what most of us try to do. So Patty, you're an expert in HFpEF, basically. Good job. And then here's what I mentioned about spironolactone. So most of us will try to get them on spironolactone if we can. I will say that for me personally, if they are not good at getting labs and follow-up, I will not start people on spironolactone, because after the first trials of spironolactone were studied, deaths from hyperkalemia skyrocketed. So I actually don't usually start spironolactone in the hospital. In fact, I wait for them to prove they're going to come to my clinic. But if they can, I do try to get all of these people on some spironolactone. I've seen a lot of people think that spironolactone is going to give them some diuresis. It really is not an effective diuretic. So I don't worry too much about volume with spiro. And then what I try to do is I actually, whereas in systolic heart failure, I maximize their ACE inhibitor or ARB and their beta blocker before I add the spironolactone. In this case, I will usually add it in addition. So I may even come down on my ACE inhibitor to give me some room for spironolactone, just because it's the only agent that has any signal for benefit so far. So that's, again, you have to decide in your particular patient if they can handle it, but I do try to get them on that. And then ARBs, there might be a signal for reducing hospitalization, so you might want them on an ARB instead of an ACE inhibitor if you can. And then here is where I was mentioning that we've studied it, but PDE5 inhibitors, so that's sildenafil, Viagra, phosphodiesterase inhibitors, and nitrates did not do anything for these patients, and they didn't give them any benefit, so I don't try to put them on those agents. Questions about any of these guidelines? I mean, it looks very similar to systolic heart failure, right? With the maybe exception that spironolactone is a little bit more frontline. But again, this will probably change when we have some more studies. So just to put it into a little bit of context as we wrap up, this has always surprised me because, and this actually is speaking to the other patient you were discussing, Patty, this disease can trick you into thinking it's not that bad. When you see an EF of less than 20%, that gives everybody a little bit of chest pain. But EF is normal, grade 3 diastolic dysfunction, what does that mean? Who cares? But unfortunately, the mortality is quite high. So this is from a cohort study. But if you look at 1 year from their first hospitalization, you've got a 30 to 40% mortality rate. So once they have to get into the hospital for this, they actually have quite a high mortality, and we don't have much we can do about it. So this, for me, kind of raises my urgency to try and keep them as well controlled as I can, to see them more frequently, just like I would a systolic heart failure patient, and to recognize that this is a deadly disease, even if it doesn't necessarily seem that way. Okay, so in our last couple of minutes, questions, comments, or, sorry, iron deficiency, I wanted to circle back to that. We don't have specific evidence in HFpEF, but we do have evidence in systolic heart failure that treating iron deficiency is beneficial. So in this patient with the low hemoglobin, we referred him to GI, especially with the dark tarry stools, very appropriate. But I would check his iron studies, and low ferritin or a low percent saturation below 15%, those are indications to treat with iron supplementation. And so we're kind of becoming a bit more aggressive about iron in the setting of heart failure, so I think reasonable to do that in these patients as well.